and this aortic buckle is very, very prominent. So this is usually typical for elderly person. And so that doesn't mean that this is like a disease, yeah, or a serious disease, yeah. So this is just sign of aging, yeah. So basically we just keep this in mind that we don't need to look for something serious, yeah. And compare the situation when we see aneurysm. Yeah, aneurysm, they are different, but usually they make the mediastinum look special. So this is not really typical aneurysm. This is post-operative aneurysm. See the features of operation. Yeah, again this metallic sutura. And so this is diseases, yeah, they are basically one compartment aneurysm, ascendens or arch or like distended, and you can see the typical examples here of different compartment aortic aneurysm. So they change the shape of mediastinum in a very specific manner. So sometimes we can say some things about aorta, yeah, but basically, yeah, so we delegate, yeah, our work to CT or MRI specialist. And next thing in our miscellaneous, that will be Healy, yeah. Again, yeah, keep in mind this picture, this is norm, yeah, the location, yeah, the width up to 3 centimeters, yeah, we should see, again, remember, white and black stripe, yeah, vessel and bronchos, yeah, and catch the idea how they can be different. So this is normal Healy and this is non-normal Healy. Yeah? So what words can we use and how do they name it? Well, basically, yeah, this is oversimplification, yeah, but for just the first acquaintance, yeah, like abnormal Healy, these are enlarged Healy. Enlarged Healy, that means that they are more wide than they're supposed to be. That means that we cannot see these two stripes, yeah, because they are obscured by something inside the Healy, yeah, and that means that their border, remember, it should be like a waist, yeah, yeah. In situation, this is norm, yeah. This contour should be like a waist, and in situation, yeah, they are enlarged, yeah, no waist, yeah, just it's like a obtuse angle, yeah. So what does it mean? Usually that means that instead of what we usually see in the head, what we usually see are pulmonary artery and bronchus. And if we see them like enlarged, that means that we see a combination, yeah, wide mediastinum and enlarged Healy. How do you think? Where do they see this? When do they see this? Usually this is lymphoproliferative disease because there are many lymphatic nodes in the Healy and in the mediastinum, and this is usually, well, not every time, but usually it's a systemic lymphatic proliferative disease. So usually they see it like this. Again, this is oversimplification, just basic ideas to catch, yeah, and to feel about, to think about, yeah. Other maybe useful signs which you should pay attention to. For example, yeah, this is white stuff, yeah, in the enlarged Healy. What does it mean? Calcification. Calcification. Is it helpful? Do you know diseases which like to be calcified? Yes, yeah. Some infections, yeah, like tuberculosis, for example. Some diseases, for example, like sarcoidosis. So this is also helpful, yeah, and we use it, yeah. And when it is asymmetrical in this manner, yeah, we still see some structure, yeah, but the white part is really, really bright. It can be about specific process. For example, this is a patient with pulmonary arterial hypertension, yeah. So this can be more than just one answer to enlarged Healy, yeah. But again, basically, and what is the most important thing, think about cancer and lymphoproliferative diseases because they are really important, yeah. And lung marking. This is really complicated and tricky because to feel that lung markings are abnormal, first you need to have an understanding what is normal, yeah? And to have this, you need to have experience. But again, I just want to get acquainted you, like to introduce to you just basic patterns which can be representative of some diseases, yeah? Once again, pay attention to normal lung markings, lines and dots, yeah. Anatomically, pulmonary arteries branches, yeah, going from center to the periphery, yeah. So if you see it like this, so how we can describe these lung markings? They are really, really rich, yeah. They are really wide. Things like they are a little bit widened, yeah. And we see more of them in the outer layer. Sometimes it seems like they are occupying even the outer layer. And basically, it's more clearly seen in the lower regions. So well, this is what the name enhanced line markings. Enhanced line markings, yeah. So their geometry is more or less the same, yeah, from the center to the periphery, and basically this is like pulmonary artery, but it's like really, really exaggerated, yeah, like really, really like this. Oh, and sometimes the contours, the edges of these line markings, they are kind of a little bit fluffy, yeah. And this is, do you feel it's different? It's different, it's different. So can we describe this picture? So what do we see there? Again, yeah, these markings are really, really bright, yeah, and we see more of them, but they are not only bright, they are really, really deformed, yeah, misshapen, yeah. They produce some geometric figures like circles, like crosses, yeah, and yeah, they go in very different directions and not like usually pulmonary artery do. So the geometry, yeah, is completely different. And that is what we name enhanced and deformed or misshapen, how do you like better, lung markings, yeah. So, what is important to understand? When they say that this is enhanced, that means that these are enlarged vessels. And more often, this is the situation when we see not pulmonary artery, but really, really enlarged lung veins, yeah. Especially and more often we see it in situation with cardiac failure, yeah. So this is what we name enhanced vessels. And probably you remember, I don't know if you catch this in your how do you know propedeutics or how do you know propedeutics class? Did you discuss curly lines? No? They see interlobular things, yeah, interlobular spaces, yeah, like white lines because they have more fluid than usual, yeah. And so this is how they see this. You see this is highlighted, and this is how they see it in reality. This is how they see it in reality, and this is how they see it in CT, yeah, these lines in a outer layer, yeah. Though they can be and A and B types, but more often they see B types. Like sometimes they see they also there. And so you see that in large vascular markings, yeah, they are usually accompanied by these curly lines because the same reason, yeah, cardiac failure and yeah, inability of the heart, yeah, to push the fluid out of the lungs and not out of the vessels, but also from the interlobular fissuras, yeah. So this is speaking about this deformed thing. That means that the basic of this deformation is fibrosis. So fibrotic tissue, which is growing, yeah, in vessel walls, in bronchial walls, in interstitial like this, or you can see this there and there. Can you feel what is the diaphragm shape? They are very special. It's like flat surfaces with peaks, yeah. So these peaks, they are named juxtaphrenic peaks. This is fibrosic tissue adhesions, yeah. So this is a sign of further diseases like inflammations and fibrous tissue productions. Then it is like the whole diaphragm. Sometimes it's named Mont Blanc sign, yeah, like a mountain view, yeah. And so these peaks, they are highly representative of pneumofibrosis, and they usually go, yeah, in hand, yeah, like enlarged and deformed lung markings and juxtaphrenic peaks, yeah. So again, yeah, feel this difference, yeah. Again, enlarged vascular, yeah, these vascular like linear curlies, and pay attention to the heart. The heart is really widened, and pay attention that the patient has a cardiostimulator, and so this is a cardiac failure picture, yeah, and this is pneumofibrosis, and it's basically more often accompanied with emphysema, like in chronic obstructive lung disease, yeah. So this is like this, yeah. Pay attention to this, yeah. So, and feel this difference, yeah. We can have pneumofibrosis in situation of chronic obstructive pulmonary disease, and in this situation, it's usually in combination with emphysema. Feel the shape of the lungs, yeah. And actually, this is an elderly person. Pay attention to this aorta, yeah. And if we have a closer view or we have a CT, inside this pneumofibrosis we can find real bronchoectasis. So this is one situation, and this is the situation which is completely different. So again, yeah, they see this misshaped, yeah, enhanced, yeah, lung markings due to pneumofibrosis, but in this situation no signs of emphysema, and you feel what is going on. There is a year between these images of the same patients. What's going with the lung volume? It's diminishing. Pay attention to the position of diaphragm. So in this situation, this is connected with what we name lung interstitial fibrosis, yeah. In field is different, so it's about lung interstitial fibrosis, yeah. And yeah, the shape, yeah, of this misshaping, yeah, is like something like this. How do you name it? What is like the bees? Okay, the heart. Again, good picture for those with a good visual memory. Yeah, where to see, where to look, what to pay attention. Yeah, so we have to pay attention to the cardiothoracic index. Remember, up to 50%. And these are the signs where we can look for cardiac failure. We'll discuss that in detail a little bit later. So again, yeah, right now the heart is not our problem. We're delegating it to who's looking at the heart? First of all, I mean in radiology, let's see. So what we should recognize, first of all, some shape of the heart is really helpful to think about something, some diseases. If you see, instead of heart which is in good shape, that means it has several X, yeah, and you see something in the shape of a bottle. How do you think, what is the disease?
Cardiomegaly.
And this fluid is obscuring, yeah, the real shape of the heart, and they see something like this, yeah. Yeah, once fluid, yeah, and it's obscuring the real shape, which should be like sphere, yeah. Each compartment of the heart, each big vessel should produce its own arch. And in this situation, we just see something, yeah. So this is hydropericardium, yeah. And if you see something like this is also very recognizable. What do you see in this heart? What is the edges? How do they look like? So this is another type of pericarditis, yeah. Okay, if you see, yeah, the heart not in the shape of the bottle, just like this, yeah, but in a very special shape with a very big waist and very big left size, yeah. So what does it mean? How do you think? Yeah, remember what was the left border? What this border was? Left ventricle. So what does it mean?
Left.
Big. In what diseases? We can see what the name left ventricle aneurysm. Yeah, and then we'll see a heart in the shape of a duck. Yeah, does it look like a duck? Like a toy duck. Yeah. Like a toy duck. Yeah. So this is how it looks like. And well, we don't see it often right now, but if it is a severe mitral valve abnormality, yeah, we can see a mitral shape of the heart, and it looks like this. Big left atrium turns the heart into such special shape. So if you want, yeah, you can look a little bit deeper. Yeah, again, inside note section there are more detailed description. Yeah. So my idea is, like, we are not doing the full diagnostic work, but if we see something representative through the shape of the heart, yeah, we make some conclusions and some recommendations. But what we do, we are looking and we can see in a really clear manner and a really simple manner the signs of heart failure. Yeah, because how it works. Yeah, so the lungs, they are like our possibility to see, yeah, the real vessels picture. Yeah, and so if the heart cannot work like a good pump, we can see step by step how the fluid is filling and filling first lung vessels and when alveoles, yeah, and everything what we can see, yeah, for example, yeah, the spaces between pleural sheets and pericardium sheets, and so, yeah, that is what we can see for sure, yeah, and so you think as you like, yeah. So what we are involved, they are paying attention, yeah, and taking into account the heart size, yeah. The bigger the size, the worse is the situation, and when, yeah, signs of pump malfunction, yeah. So first of all, Healy, they will become enlarged and unstructured when, yeah, we are looking at the sinuses, yeah, these angles, yeah, they should be sharp, and if they're not sharp, there is fluid collection there, yeah, and then they are looking, yeah, at the lung markings, and they are getting bigger, and we can add there these curly lines. And if everything is completely bad, so we'll see real, remember this extensive bilateral consolidation in heart failure, so we'll see lung edema, yeah. So step by step, yeah, usually it is really step by step, yeah. So first of all, normal vascularity, then a little bit more vessel, and then interlobular vessel and tissue edema, and at the end, yeah, like fluid inside the alveoli, yeah. But in reality, yeah, it usually can be a mosaic, a combination of these, yeah, and we can see something like this, yeah, and we can see it something like this, yeah. So remember, when we discuss bilateral extensive opacities, we name it butterfly wing signs. But if you are more brutal type of person, you can remember it like a bat wings appearance. Some people do it like this. Yeah, they both work. So that means that this is lung edema. So this is severe cardiac failure, and we can see it clearly, really quick, with no problems for the patient. So this is a very good way to see for cardiac failure, yeah. And remember this picture, yeah, from the section about vascular markings, and this is a typical picture of cardiac failure. Big heart, yeah, bad Healy, bad lung markings, yeah, and this butterfly thing, and again, yeah, this linear curly, well, and a little bit, well, probably what we don't see there, yeah, these lungs are, these angles are still sharp, but it can be in different way. Actually, I can imagine that this heart is a little bit in the shape of a bottle, and this can be also a part of cardiac failure, because that means that there is hydropericardium, yeah, and so this is how it can work, yeah. Well, not every time we see cardiac failure in this like textbook manner. Sometimes they see it in a more complicated manner. So in this patient, we see at the same time both cardiac failure and signs of respiratory distress syndrome, and usually they go side by side, yeah? But in typical situation they see it like this. So when let's add something about diaphragm, yeah. So we already discussed, who remembers what's this?
Fibrosis.
Euxtaphrenic peak, yeah, fibrosis, yes, you're right, yeah. Well, and this is a sign of further, yeah, not further, former inflammation, in operation or something. For example, in this situation, yeah, this is a patient which has partly part lung removed in previous years, yeah. So let's add something what we've now discussed before. So let's discuss what do they think about situations when they see diaphragm a little bit higher or elevated than it's supposed to be. Yeah. Well, first of all, if we see it elevated, especially in combination with mediastinum displacement to the same direction, that is a very, very important sign of lung volume loss in this direction, in this part. And that is highly suspicious of a tumor, of a cancer, yeah, of atelectasis at the lower lobe, yeah. So like in this situation, you see, we can even see in that this is trachea, and then this is main bronchus, and it's compressed, and this is, yeah, this triangle shape opacity, yeah, and it's in combination with high diaphragmatic level and mediastinum shift, yeah. So this is highly suspicious of tumor. What else is highly suspicious of tumor, yeah? When the diaphragm is elevated but without mediastinum shift, it's like up level position. So in this situation, it's a little bit special shape. But in this situation, it's just in up position. And this is named phrenic nerve palsy. And we see this again in situation. Then the tumors are compressing diaphragmatic nerve, and it doesn't work. Yeah, it could be then it is an apical tumor or like a really, really typical tumor, central tumor close to the hilea. So that is what we see. Yeah, and what else can we see? We can see situation then. Well, sometimes it's like we see it like diaphragm is elevated. Sometimes it's a very special picture, is really difficult to describe in words, yeah. But we see that the level, yeah, this border between thoracic and abdominal cavity is really different. Well, I name it's like elevated and decorated diaphragm. So that means that it's not only on high level, like the picture, yeah, behind, yeah, in lower area is kind of very special. So this is usually highly suspicious of diaphragmatic hernia, yeah? And this unusual shape, this decoration, is due to the presence of abdominal organs such as stomach and intestines, intestinal tract, and we can recognize where it is situated, yeah. So, yeah, pay attention to this, and these can be very, very special pictures, yeah. So again, yeah, and a couple of more, yeah, diaphragmatic hernia, they're very, very special. Pay attention to them. And some words about chest wall, because they can assess it, and we should pay attention to this too. Yeah. So what do they see? Fracture line and bone displacement. But pay attention that rib has a very, very specific shape. And to see it like this, yeah, it's good to see it like this, yeah. So you need to have a good projection. What do we need to do? We need to make fluoroscopy to turn the patient like there, yeah, and then they do it. We can see the fractures in a clear manner, yeah. So because, yeah, they turn the projection, yeah, they change the projection, and that is how we can see the fractures, yeah. So it's the same patient, and we can see these fractures clear there, and well, it's also there, yeah, because this complicated, yeah, this curved shape, yeah. So, but then pay selections inside the lung, yeah, and inside the pleural cavity. So let's see, what do we see there? Yeah, first of all, we see hemophoraxis. Remember hydrophoraxis? These are the same thing, yeah. When in this situation, that is what we name lung contusion. That means that the blood, yeah, since, yeah, the patient has several rib fractures, yeah, is collecting inside lung tissue. So this is, which is important to see, yeah, and to do something about that, yeah. Inside bone instead of bone, that means that, see, not bone, but we see lucency in bone, yeah. It could be bigger, it could be smaller, it could be of different shape, of different structure, yeah. But that is what we can see for sure, and that is very typical for cancers. By cancers, I mean like epithelial tumors, yeah, like gastrointestinal tract tumors like to do like this, lung tumors like to do this. my breast cancer. It's like typical for breast cancer, yeah, to produce osteolytic metastases, yeah, and they are more or less clearly seen on other pictures. Another type of metastasis, this is the thing which we name osteosclerotic, and that means that they are dense, they have bone material in them, yeah, and the bone tumors, but the chest wall bone tumors, yeah. And we can also see that they can be benign, like in this situation, and they can be malignant, like in this situation. See, this is a tumor, and this is a big soft tissue component which is growing into the lung, yeah. This is osteosarcoma, and this is chondrosarcoma, yeah. And again, yeah, this is a big tumor. We see it like a tumor, yeah. There's a special calcification pattern, yeah. Pay attention to this, yeah. So this is, yeah, what we can see in the chest wall. Because it's kind of summarization. And probably you'll find something new. First of all, I like this picture. And I really recommend you to meditate at this picture, yeah, in a close view, yeah, because all the structures which we discussed, how they should look like, yeah, they are clearly seen there and they are labeled. So I really recommend you this picture just to keep in mind what we should see, yeah. And when our approach, and it works not only with X-ray, something you can use looking at any image. Well, our first. No.
Related to heart.
Tumor. We missed it, and it grows like twice, yeah. And so that means that we have to be very attentive. So not only recognize happily, I know this disease, yeah, but yeah, to think about, yeah, maybe, yeah, it can be something important, yeah. And another thing, how do you think? What's this thing is? This and this. What is this artifact? Drainage tube. Drainage tube. What I want to see to tell you, yeah, so especially in situation when we are draining the pleural cavity, well, sometimes it's kind of tricky to understand what was first and what was the next step, yeah. So first it was air and then fluid collection, or just the other way around. And so the position of the drainage tube could be the key. So if you see this drainage tube, this tip in up direction, how do you think? What is the problem? What we are drainaging? Air, yeah. And if it is in this position with tip down, that usually means that this is fluid drainage. Yeah? So keep this in mind. Yeah? So this is simple rule that can be really helpful. And these are these pots I've told you about. Yeah. So the pots which we use, yeah, for long infusions. And you see all the pictures, they are positive images, yeah. The metallic from the bones, they are really in black color, and the lungs are in white color. So that is because, yeah, the insertion of a pot is an interventional radiology procedure, yeah. Because this part, yeah, it's behind the skin, and this part inside a central vessel. They are really simple, and in the note section, this really simple. How do they see? How do they look? What the name? Central venous catheters. Yeah. So this is also what we can see in this section. When some other stuff, yeah, let's figure out, yeah. We used to see in a couple of pictures this sutura, the sternum sutura, and how do you think what these white short lines are?
Heart.
The content, yeah, how to look for a disease. That's not my idea. I borrowed it, but I like it very much, yeah. So the concept is like this. First of all, don't miss displaced diaphragm, displaced media. So if we see something like this, that means we shouldn't ignore that. We see opacity. So an elephant in this situation is opacity, yeah. And when, how about what we named it? Ears, tusks, trunk, and skin, yeah. Features, what should we pay attention to? So what is this type of opacity named? Yeah, what is important in this opacity? It is big. How do we name this opacities? Extensive opacities, remember, yeah? And when what do they discuss about extensive opacities? What should they pay attention to? Yeah, the position. First of all, is it unilateral or bilateral? It is unilateral. And what should they pay attention to? The position of the mediastinum. Yeah, and remember, displaced in the direction of the disease, aphlektasis or situation after pneumectomy. Yeah, and the other direction, plus size, yeah, effusion, and the central position, pneumonia, yeah. So remember this, yeah. And so on this, the elephant. So what we can pay attention to? What is the difference between these are cell formations, and this is something with destruction, yeah. And these are metastases, and this is septic infection, yeah, with abscess, multi-abscess formation, yeah. So this is how it works. Okay, let's name this elephant. What does it mean? As a loop or a segment or a group of segments, yeah. So this is the direction of our, yeah. So in this situation, one segment, yeah, one segment, yeah. And so what we can pay attention also to, like this, you see, there was a pneumonia, in clinical it was pneumonia, and we treated this patient with antibiotics, and 2 weeks later we produce another picture. What do they see? How will you describe this picture? What do you see there? A narrow triangle. And if they see something like this, what can they understand? So there was inflammation there, and we treated it, and we are successful in this, but there is still volume loss, and so that is highly suspicious of aphlektasis and central cancer. Yeah, and central cancer sometimes do like this. We cannot see them directly. We just see the consequences, and the consequences was bad ventilation of the segment, pneumonia, and when no pneumonia, aphlektasis. Yeah, so this is how it usually works. Yeah, and let's see this last picture in this section. Yeah. So, what is an elephant there? Well, sometimes it's less obvious and it's kind of tricky. But it also works. Displaced, yeah? So, if we think like this can be an elephant, so that will be our root. We should figure out, so what's wrong? What does it mean? Yeah, that means that there are some volume changes, yeah, some volume changes. Well, and if we look more attentive at this section, yeah, and if we take a look from the center to the outer area, so, and at the same thing, this, what do they see there? What is the color? This is more air, and if it is air, what do they pay attention to? If there are lung markings or not, yeah, and do they see any lung markings there? No, so that means, do they see, yeah, the border of compressed lung? Do they see it? Here it is. This is a pneumothorax. When if you pay attention, but there is a horizontal line. This is pneumohydrothorax, yeah. And if they see the displacement of the mediastinum, what should they mention? That is a tension one, yeah. So this is how it can work, yeah. So if you have more experience, probably you will start with that thing, yeah, and that will make your wake shorter. But this is easy, and it's okay to do it like this, because this is the scheme, yeah, which we can, which is recommended in English tradition. So yeah, this is this, what's the name, lesion descriptors, yeah, and this is just the list. I don't like it because, yeah, for my Russian mind, it sounds just a list. Yeah, and Pochifora Enrico sounds for me like something very, very expressive. But if it is better for you, you can, yeah, do it like this, yeah. So this is there, and there is an example how you can use it, yeah. So you can use it, you can look for it, yeah. So, and if we continue our discussion about, yeah, making the conclusion, the right conclusion. So some abnormalities are big, they are obvious, but some abnormalities, they are small, like mouse, yeah, minor abnormalities. And how not to miss minor abnormality, yeah, like obvious abnormality, you just look and you see. But to see something what is minor, you need to have some instruments. And let's discuss these two instruments which are very, very popular. So one instrument is yeah, is to look at the boundaries which we usually have to see at the picture, and if somehow, somewhere we don't see them clearly, yeah, so this is named silhouette sign. Yeah, when we don't see one of the mandatory border clearly, yeah, we name it silhouette sign. Yeah, we see it not in basal segments. If you don't see, remember there should be a paratracheal line. Think about tumor in the mediastinum. If you don't see the wall clear, something like this, think about chest wall tumor, pleural tumor. Yeah, so it works like this. Yeah, and to continue. Yeah, if you don't see the, who remembers what's this? Aortic
Aortic
knuckle, yeah, or aortic pulmonary window, also we can use it. So this is the most popular, probably the most practical, yeah. So it's A, B, C, D, E, and that means, yeah, pay attention to the apices, because we can easily